Good morning, good afternoon, and welcome everyone to today's webinar, Spiritual Care for Nursing Home Residents with Dementia, Building a Chaplain's Musical Toolkit. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer system by default and are muted. Should you have any technical questions regarding your audio or visual, please feel free to type those into the chat box located in the platform's dashboard. You'll have the opportunity to submit text questions for our presenter by typing your questions into the questions pane of that same control panel. We're going to try to see what we have at the end of the hour. If we don't have time for Q&A, rest assured that the questions will be saved and I can get those to Dr. Masko and the staff, and we can review those and be in touch. We do have several QR codes. Both Dr. Masko has some and we have some for a couple upcoming webinars. So if you have a smartphone handy, it's pretty easy just to take a screenshot of that QR code and it'll plug you right into the registration page. We also have provided small bit.lys. I know Dr. Masko did for the things that she wants you to engage with during her presentation. And with that, I'd like to introduce Kathy Lines, Professor of Social Work and Gerontology at St. Mary's College in Notre Dame, Indiana. Kathy's also the co-convener of the Transforming Chaplaincy Elder Care Research Network, along with Sarah McAvoy. Kathy?
Thank you, Andy. That was fantastic. So I'm about to introduce our speaker today. Just so delighted that she is willing to share preliminary information about a research study that we've been working on. Meganne wears multiple hats. She is a board certified and licensed music therapist, specializing in adult hospice and palliative care. She's an assistant professor and director of music therapy programs in the Purdue School of Engineering at Indiana University, Purdue University, Indianapolis. Dr. Masko's clinical research focuses on music therapists provided spiritual care. Let me say that again. Her clinical research focuses on music therapists provided spiritual care as part of the hospice interdisciplinary team. I had the good fortune of working with her a bit on this project, and as I said, I'm just very delighted to have her present on her work. Welcome, Meganne. I look forward to your presentation.
Thank you. Can you hear me okay?
Yes.
All right, outstanding. So as Kathy said, my name is Meganne Masko. I'm the Director of Music Therapy Programs at IUPUI, and I'm also a faculty member in the Evans Center for Spiritual and Religious and Spiritual Values in Healthcare at IU Health. I'm so excited to talk with you all about this project and what we've been working on through Transforming Chaplaincy and the Palliative Care Research Collaborative. First things first, on your screen, you should see a QR code on a red background, and go ahead and scan that QR code. It will take you to Spotify. I've already created a collaborative playlist for us for this webinar. I've added, I think I started out with 3 songs just to get us started. So you can go into Spotify. If you don't have a Spotify account, it may ask you to create one. It's fine, it's free. But if you have Spotify, go ahead. It should take you right to the collaborative playlist, and you can start adding music, whatever music you want to that playlist, whatever feeds your soul, whatever's getting you through the day, whatever's meaningful for you, or maybe it's something that you have used in your own practice with patients that you'd like to share with other people. And the nice thing is that collaborative playlist then will be there for all of us to be able to go back to whenever we want. So our overview for this webinar, the first thing we're going to talk about are research aims, the research aims. The picture here is an overview of Paris. Paris is my favorite city. I was just talking about Paris with Andy and Kathy. So this is a beautiful overview of sunset in Paris. We're going to talk about research aims and the methodology for this study. And then I'm going to share some of the very preliminary themes and findings. The research team and I have just started doing the analysis of the focus groups and interviews that we conducted. So these are, when I say preliminary themes and findings, I very much mean preliminary. And then hopefully the bulk of our time will be spent with me offering some practical tips to you and things for you to think about when you do want to use music with your patients, specifically patients who have Alzheimer's and related dementias. And then the last thing we're going to do is instead of doing Q&A, really what we're going to do is I have a little Qualtrics survey for you to fill out, and there is a QR code. There will also be a web link that I'll put in the questions area so that you can access it. And there are 3 questions for you to answer, and that's going to be your opportunity to provide feedback to me and to the other members of the research team to let us know in the future what kind of information you would like to receive from webinars like this or from other training opportunities. So first things first, the research aims. The first research aim was really to develop a very preliminary description of how nursing home chaplains provide care for persons with dementia. And that's because there's just not a lot in the literature base. When the research team went looking for information to actually answer this question, we realized that we needed to start talking to chaplains about what they were doing. And then for me, as a music therapist, I was very much interested in learning how chaplains were using music and how chaplains were collaborating with other clinicians, such as music therapists, to provide spiritual care for patients with dementia. So they're very broad research aims, and not surprisingly, because they're broad research aims, that pushed us in the direction of taking a qualitative approach to learning more about these research questions. So first off, the research team, Sarah McAvoy and I are the co-PIs of the team. And then we also have Shelley Varner Perez, who is a chaplain at IU Health and a PhD student. Kathy Lines, you've already heard from. June Kwok, who is a faculty member in Texas. George Fichette, I'm sure you all know. And Dr. Lexi Torkey from IU Health as well. It's a fantastic research team. They've been great to work with. At one point or another, I conducted all of the interviews and focus groups, and I was joined from time to time by Sarah, Shelley, and or Kathy. So we've all had the opportunity to listen to you all if you were able to participate. So what was the research process? First thing we did was we had a lot of conversations and created our research aims. And after we created the research aims, that helped us figure out who we really wanted to talk to and figure out the inclusion criteria. Once we established our inclusion criteria for who could participate in the study, the announcement went out via social media, LinkedIn, email, all of the avenues and venues that we could find to invite people to express their interest in participating in a focus group. And then we asked folks to provide their contact information and demographic information. And the demographic piece was because we wanted to try and have a group of participants who were representative of chaplaincy in general in the United States, and also hopefully a little bit more reflective of the actual population of the United States. Once we had that list, and there were many, many people who said that they would like to participate in this study. Not everybody had the chance to, and that was because you all are incredibly busy. And life as a chaplain is a little chaotic. I've worked with chaplains for about 17 years now. So codes happen, things happen. You all need to go and have time with your patients and their family members. So not everybody was able to participate. It also was very difficult, not surprisingly, to find times when multiple people were available at the same time, which is how we wound up doing some interviews as well as focus groups. we did get those date and times set up and communicated to participants. Like I said, not everybody was able to participate. And if you are one of those people who offered to participate, but then you were not able to do so, I want to make sure that I thank you even for your willingness to participate, because it can be very difficult to find people who want to take part in research. So as a researcher, I thank you very much. We had so many people who expressed interest. Sarah McAvoy said to me, she goes, "Wow, is research always this easy?" And I said, no, no, it is not. Once we had our dates and times set up and we were able to communicate those with folks and confirm them, then we did have a series of focus groups. And some of those focus groups wound up becoming interviews because of scheduling issues. And then there also was a follow-up survey that went out to everybody who participated in either an interview or a focus group. And we conducted those focus groups from April through June of this year. And then once we had all of the recordings, they went off to our amazing transcriptionists who turned around, sent everything back to us. And now we're in the process where the sort of the coding team is going through and doing the initial data analysis. We're in the process of creating the code book for the analysis, and we hope to have our analysis done actually hopefully by the end of February. We originally were aiming for something sooner, but you know, there are a lot of holidays between now and the end of January. So what are the preliminary themes? First of all, I cannot tell you how much you all love what you do. I'm sure you know this. One of the questions we asked was for people to tell us about the joys of chaplaincy with folks who have Alzheimer's disease and related dementias. And it was so unbelievably clear that you all absolutely love what you do. And you said it multiple times during your focus groups and interviews. The other thing that came through was that you care deeply about your residents, about staff members, and about family members. And that relates to sort of the third big initial finding, which is that you as chaplains are being asked to do more and more and more in your jobs. Part of that is in relationship to COVID and a reaction to COVID. Almost to a person, chaplains who participated talked about the increased need to provide staff support. So not just support to residents and to family members, but also a real increased need to provide support to staff members. And again, that's not surprising, given what we've all been living through for the past 2 years. Many of you were also asked to take on additional jobs in your capacity as being a chaplain. A lot of you had many technological lessons that you never thought you were going to need to learn. A lot of you learned how to do things that you never thought you would be able to do. And I will try to fix that spot. I can see that there's a problem with the Spotify link, so I will try to get that fixed in just a second. You are facing a whole lot of challenges. At one point, Kathy and I were talking after a focus group, and she said, we need a word that goes beyond burnout. That what some chaplains are experiencing really goes beyond burnout. Burnout does not cover it. And you are facing challenges in terms of the physical challenges. Some of you have, patients who have been moved around. Your facilities have been reorganized. A lot of you work at facilities that are understaffed, and you are doing your best to make up for that difference in staffing. So the challenges that you're facing are very real, and a lot of you are extremely tired. That was something else that came through. But again, I wanted to begin and end with this, that you love what you do, despite all of the challenges, and we asked you to name your challenges. Despite all of those very real challenges that you all are facing in your work as chaplains, you absolutely love what you do. And as somebody who loves to work with chaplains, it's always a joy for me to see that. I'm going to take just a second here to open up my Spotify and make sure that it's, and I can share the link in the chat. So give me just a second. Oops. Let's see here. Andy, I'm sending it to you too.
Okay.
Okay. All right. So our preliminary themes that came up in our analysis, that have come up in our analysis so far. The first one, there's a lot of information about your facility characteristics. I personally had no idea how unbelievably varied long-term care facilities are from state to state within the United States, but you all work at vastly different facilities. Some of you have a floor, some of you are covering multiple facilities, some of you are covering in-home and an inpatient facility. So those preliminary, that you talked a lot about the actual characteristics of your facilities. The next theme that we have starting with is spiritual care tasks and activities. So you all told us exactly what it is that you do with your patients, with your residents. And I tend to use the word patients. My background is in hospice and palliative care, so the terminology that I use is patients. This really focused on things like providing services, so religious services to people, whether those were denominational or non-denominational. If on the Christian side, if we had a couple of rabbis that we spoke with who talked about, Shabbat services and High Holy Day services. So a real focus on providing religious services. Bible studies came up quite a lot too, and prayer. And then after that were those one-to-one visits with patients that you all make. And then again, a lot of care for staff members and care for family members. Something else that came up, and this goes along with changes due to COVID, is how your work has changed because of COVID. And one chaplain in particular talked about patients becoming adapted to isolation. And that quote has stuck with me ever since the chaplain said it. And that chaplain was describing how things have changed because of COVID. And so, it used to be that there were a lot of folks who maybe were in jerry chairs or wheelchairs or just regular chairs who might be out in the hallway or walking around the hallway or in a dementia care unit. And but because of COVID, especially if there are active infections in the facility, a lot of folks spending a lot of time in their rooms with the doors shut. And that's where that idea of becoming adapted to isolation came from. Chaplains, for the most part that we spoke with, also talked about seeing a fairly rapid decline in their residents. So that the disease process seems to be speeding up because of the isolation. A concern, a challenge that was shared with us as a change due to COVID was, for many, many months, for over a year, a lot of people were not able to gather communally to share in religious services, whatever they might be. And that was a challenge emotionally and spiritually and psychologically, both to staff and to residents. A lot of you have learned how to do closed circuit television. A lot of you have learned how to use YouTube. And like I said, you've picked up a lot of skills you didn't think you were ever going to need to know. Not surprisingly, the fourth preliminary theme is about using music and how you all are using music with with your residents. And we're going to get into that more in just a minute. It is not surprising to me as a music therapist who has worked with chaplains for, like I said, about 17 years, that you all tend to use music as a go-to on a regular basis. And my hope today is to give you a little bit of guidance of how to do that perhaps more effectively. And then our last preliminary theme really focused on the challenges that you all are experiencing in your work. So I hope, if nothing else from this webinar, you come away with some very practical tips for using music with your residents. And I also hope you know that you are seen, and that you are appreciated, and that at least the research team recognizes the amount of work that you all are putting into what you're doing and the challenges that you're facing. And you are very much appreciated, as is the work that you do. Okay, my favorite part, practical tips for using music. I am a board certified and licensed music therapist. My license to practice is actually from the state of North Dakota. I moved to Indiana from North Dakota. North Dakota was the first state to pass licensure for music therapists in the United States. And I happen to be the bearer of license number 1. So I maintain my license to practice music therapy in North Dakota because I have a very special license number. So let's talk about using music with your residents. Okay, the first thing I want to talk about is mitigating harm. And music has been, it is, and it can be used as an actual weapon. It is actually used as a weapon of war. And there are now declassified Senate committee hearings, records of Senate committee hearings that you could go and you can find. I actually use them when I teach my undergraduate students, that detail how governments use music to harm human beings. And so whenever we have something that can be used as a weapon, we have to make sure that we are using it carefully and with a great deal of thought, because we want to assess the potential for harm and then act and plan accordingly so that we can reduce that potential for harm as much as possible. So some examples that are a little over the top, but one of the examples that we use a lot in music therapy when we're teaching students about this idea of making sure that we are assessing for potential triggers of traumatic events is that, I don't know how many of you know this, but during World War II, when Nazis were putting Jews in concentration camps, that Mahler, the composer Mahler, was a particular favorite of the Nazi movement. And so Jewish musicians, professional musicians who were imprisoned in these concentration camps, would be asked to play the music of Mahler for their captors. And Mahler was himself very anti-Semitic, sort of famously so in the world of music. And so we just, as a general rule of thumb for music therapists, we should avoid using Mahler with Jewish patients, because there is such a history, a generational history of that music being used to specifically harm people in such a visceral way. So another issue to consider is if the person with whom you are working is a combat veteran, a survivor of assault. Maybe they are a person who had a child who died in infancy or at any point in time, whatever the loss might be that they experienced. For combat veterans, especially as I'm now 45 and a half years old, and for folks that are my age, that are combat veterans, and a little bit younger and a little bit older, you know, the iPod became a thing. So, you know, in World War I and World War II, wasn't like you could take a record player in your tank. But if you are a 21st century soldier, then you have MP3 players, and the MP3 player's been around since the early 2000s. So military personnel have been able to take their preferred music with them where they wanted to go while they were deployed, which is great because it has the potential to help folks be able to remain emotionally healthy and to engage in positive coping behaviors. But what happens is that if a person is in a particularly traumatic event, that traumatic event can become linked with the music that they were listening to. And actually, other than smell, music is one of the fastest ways to trigger a post-traumatic stress response in someone. So we need to make sure that we know what people's previous experiences are with music. Something else to keep in mind is if a person has a history of drug and alcohol abuse, because music is intimately connected with being in bars, being at parties, being in places where people tend to use. So, and there actually is, I have a friend, Dr. Andrew Knight at Colorado State, who talks about super drugs. And because when we pair music with things like gambling, we pair music with drugs and alcohol, we can actually get like a super high. And so we have to pull apart the music from people's experiences using illicit substances, and hopefully give people other ways of using music, or even replacing the music that they've traditionally listened to, say in a bar environment, if that is triggering of their using. So and I've done work with folks in court-ordered drug and alcohol rehabilitation, and that's one of the parts of the re-education process. It's a re-educative form of therapy. When we are working with those folks, is that, you know, how is music connected to the way that you were making choices and the behaviors you were engaging in, and how can we find a new way to use music so that it is not going to be a trigger for traumatic experiences or a trigger for use of illicit substances. Those are not things that most people think about. Music, I often joke with my students that the difference between a music therapist and the nice person that comes in, you know, to play the piano at a long-term care facility is that the music therapist is always thinking about how to mitigate harm. They're always thinking about what is the potential for harm, and then how can I lessen the potential for harm. So really making sure that you ask questions so that you can learn as much as possible about the potential for a trigger of a previous traumatic event is really important. I had a patient once who I went in to go see. The patient was actively dying. I went in with the chaplain. It was a joint visit. Got there, talked with the family members. They gave me an idea of what I thought I could do when I went in with the chaplain. And I walked in and I started playing Amazing Grace, which a family member had told me would be a good choice. And the patient instantly had a visible post-traumatic stress response. Their muscles tightened up, their breathing changed, their face started to scowl, their brow was furrowed, they were moaning. It was a very clear response to the music that I had just introduced. And so I immediately stopped, which is what you should also do if that happens. I immediately stopped and actually took the patient's hand and then just started to tap his hand to try and get his breathing to settle down, get his breathing entrained with mine. And then I very quietly started to improvise some more music to, again, try to get the breathing calm, try to get those muscles relaxed, get him back to a state of at least non-active traumatic response. And when I left the room, the chaplain remained with the patient and went out to talk with the family. And at that point, a family member who had not been there previously let me know that I explained to them what happened. And the family member let me know that, in fact, that patient, who was a World War II vet, this happened a while ago, was the only person who had survived an attack of their platoon. And that person, the patient, held many of his friends as they died and sang Amazing Grace to them as they were dying. And so for him, Amazing Grace was absolutely the wrong piece of music for me to have attempted to use in that environment. But it was a piece of information I didn't have. It was a piece of information that other members of the family did not have. So just know, sometimes even when you feel like you've done your best due diligence, there's still the possibility of unintentionally triggering some kind of traumatic response. The second thing is monitoring the sensory environment. So as folks are going through the disease process, it gets harder and harder for the brain to be able to process all of the complex sensory information that is coming in from the environment. So if we think about a typical community room at a long-term care facility, right? We have overhead lights. They're probably fluorescent. There might be a TV that's on, probably a fairly high volume level. There are people who are talking. Facility staff are coming in to make sure that people have their medications, that they've been fed, that they've had their nails done, whatever it might be that they need to have done. So all of those things are types of sensory information. And then we also have the feeling of being in a chair or in a wheelchair, on a couch. We also have the sensory input from our proprioceptive sense. So your brain is constantly trying to figure out, okay, where am I in relationship to all of the objects around me? You have your vestibular sense, which is sort of where am I in relationship to gravity? If you've ever had a vertigo attack, that's your vestibular system being out of whack. So we have all of these different types of sensory information that oftentimes we don't even consider. We just sort of take them for granted. I happen to actually have a brain injury from an accident in 2017. And so I have to monitor my own sensory environment, because if the lights are too bright, if the music is too loud, if my shirt isn't quite soft enough, whatever it might be, it can really trigger. It actually, for me, it triggers migraines. Smells are another thing. So keeping in mind, the smells that are coming into people, all of that is creating a sensory environment for the residents. And so if they are doing fairly well, if they seem like they are able to handle the sensory input that is coming into them, then yes, we could probably introduce some music. If, however, the room is really bright, if the TV is really loud, or if the radio's on or a CD player is on and it's really loud, I think too about vacuuming, if folks are cleaning, just all of these sounds. And then we have this, if meals are being prepared, there might be the strong smell of food. We have to keep all of that in mind, that might not be the best time to be introducing music. Or if you do want to introduce music with a resident, maybe take them someplace else, take them to their room, take them to a quieter part of the day room, or to someplace else in the facility where maybe there's more natural light, or the smell of food isn't quite as strong. There's less ambient noise. So we're trying to maintain a good sensory diet for the residents. And that leads us to looking for signs of overstimulation or discomfort. You all have probably seen Music in Memory, and the famous George, I think his name is George, the man who they put the headphones on him and his face lights up and he gets all excited. And the Music in Memory program can be a fantastic part of a larger comprehensive sensory program for folks with Alzheimer's disease and related dementias. But we have to make sure that we are looking for signs that the person is overstimulated or they are uncomfortable. So, and we want to make sure we do that because very often the folks on whom we are putting headphones or we're putting AirPods in their ears, they don't necessarily know what it is that's happening. So we want to make sure that if we are putting AirPods in people's ears or we're putting headphones over their ears or some other kind of, using another kind of MP3 player and putting, earbuds or earbuds in their ears, that we actually are watching to make sure that that's not distressing to people. So if you see the headphones go on somebody and you notice that, maybe they're moving their head, or some folks may try and reach to try and pull them out. Dr. June Kwok was telling me about a study that she did where about half of the participants didn't like having the hearing devices in their ears. It also, if somebody has hearing aids in, I'm also a hearing aid user, and as somebody who wears hearing aids, if I have my hearing aids in and you also put headphones over the top of my ears, that it distorts the sound and it is much louder than we probably think it is. So we want to look for things like, is the person's brow furrowing? Do they look like, if they're laying down, are they rolling? Does it look like they're trying to get away from the sound source? Are they trying to touch their ears to pull out the AirPods or the headphones or pull off the headphones? If all of a sudden you see an escalation in somebody's negative behaviors, then it's one of the first things we should do is take off the headphones or turn down the volume, maybe lower the lights, whatever it might be, to just try and lower the potential for overstimulation. Okay. So another practical thing to think about is providing levels of care. So the more fragile a patient is, and you all know this, I'm explaining things to you that you already know. You know that the more fragile a patient is, the more training a person should have with working with that person. Just like volunteers can come in and say prayers with folks in independent living, right? It may not be the best idea to have volunteers come in and provide spiritual care to folks who are maybe in the end stages of dementia. So same thing with music. The more fragile the patient is, the more training a music provider should have. So the more, and this is where a music therapist can be really helpful. So if you have the chance to work with a music therapist, either one who's on staff at your facility, and I know from the feedback that you all gave in the focus groups and in the interviews that not a lot of you have the opportunity to work with a board certified music therapist. If you do, please count yourself very lucky because you have a lot of colleagues who do not and who would like to. But this is a good time when we think about levels of care to collaborate with a music therapist. So examples of levels of care using music would be for our folks who have, who are a little bit higher functioning, they still have, maybe they're healthy, well adults. In North Dakota at the facility where I practiced as part of my academic appointment, I had an intergenerational rock band. So and intergenerational rock bands are truly my favorite thing to do as a music therapist. So you can, sorry, I just got a little bit distracted by the questions. I'm going to ignore them for now. There are so many folks now who are at the age of living in care facilities, especially multi-level care facilities, who, you know, are baby boomers. And my dad, who is a baby boomer, likes to joke that, you know, nobody made it out of the 60s without learning how to play the guitar. And so at the facility where I was practicing in North Dakota, we had a huge, we had just a huge number of people who had guitars in their rooms, mostly older gentlemen, electric guitars, basses, acoustic, classical, you name it. And a lot of them played. And then we also had a lot of folks who played saxophone, drums, trumpet, you name it. And so we had a rock band at the facility. And it was a combination of folks who were college students and then the folks in the facility. And the folks who could no longer play were folks who, some of them, they couldn't play instruments anymore, but they could still sing. And so they wanted to sing in the band. And then we had other folks who could play. Then, so, you know, those are folks where anybody can lead an intergenerational rock band. You can have a volunteer come in and do that. You can do that if you have, you know, some musical training. And you don't need a ton of training to be able to do that, right? You don't need a lot of training to come in and play the guitar for people, or the harp or the piano. You don't need a lot of training to work with primarily well folks who, you know, can sing hymns and sing other types of music. We're going to talk about that in a second. But the closer a person, the more a person moves through the disease process, the more we need to think about having a more intensive level of care in terms of music. So maybe that person can't participate in the intergenerational rock band, but maybe that person could still go to a concert at the facility. Maybe that person could still go listen to somebody play the piano. We just, again, want to make sure that we're monitoring the sensory environment so they're not getting overwhelmed. But as that person, especially as they go further and further through, as they move closer and closer to time of death, then we need people who can really look for that person and look for sort of the micro behaviors in response to music. So in hospice and palliative care, most of my patients cannot talk to me. Most of my adult patients have diagnoses of Alzheimer's disease and related dementias. And so they can't tell me, right, that something is too loud. They can't tell me that they don't like a piece of music. They can't verbalize that to me. But what they do is there are changes in their breathing patterns. There are changes in their heart rates and respiration rates if they happen to be in the hospital and I can see the equipment. They have changes, you know, their brows furrow, their shoulders might go up. We might see people being sort of terminally restless if they're approaching time of death. And so there are sort of micro behaviors that we look for that let us know that we are either moving in the right direction or we're moving in the wrong direction, like we picked the wrong piece of music. And oh gosh, William Dexheimer, that's the only part of your name I can see. Thank you for catching this. Oh my gosh, I said Mahler, didn't I? I did not mean to say Mahler. I meant to say Wagner. You're absolutely right. I meant to say Wagner. What's really funny is I even have had one of his operas stuck in my head the entire time that we've been talking. The Ride of the Valkyries, if any of you are familiar with The Ride of the Valkyries, it was in Bugs Bunny. There's actually a great Bugs Bunny cartoon about Wagner, but no, yes, I did not mean to say Mahler. I meant to say Wagner. Thank you for catching that. Mahler, music is actually used, is actually filled with references to the Jewish faith. So yeah, Mahler good, Wagner no. I can't believe I did that. Oh, nobody tell my music history professor. He'll be really angry with me. And so we want to collaborate with a board certified music therapist whenever we can. And because the board certified music therapist is going to be the person who knows to look for those like micro behaviors, and kind of like what I'm doing with you now, it's good to consult with them, because you can just say, hey, you know, I've noticed that Agnes seems to be declining. In the past, she's really liked it when I sang with her during our visits. Is there anything that I should be aware of now that she seems to be declining in terms of how she might be responding negatively to music? And, you know, what should I do in response to that? What I'm going to tell you is in response to disease progression, the music does not have to get younger, meaning that it doesn't have to be music from a person's childhood. But the music should get simpler and simpler. So often, if I have a patient who is in the end stages of dementia, maybe they're actively dying, I will go in, and if holding their hand is something that has been a part of our process, then I will hold their hand. I don't ever want to unintentionally freak somebody out by using physical touch. But if that is something that we have done before and the patient has been okay with it and they are okay with it in the moment, then I will hold their hand and I will very quietly sing for them. Whatever the music was that was important to them. And hopefully music accurately reported to me as preferred by the family. So again, it's one of the take-home points for this presentation is for you to think about what are some of those micro behaviors too that you might be observing or that you can observe with patients, especially as they start to move through the disease process and their ability to tolerate and to process sensory information declines. There we go. Okay, so my next tip is for you to expand your horizons. In the conversations that we had with folks, sorry, I think William and I could have a whole conversation about Mahler. I cannot tell you how appalled and embarrassed I am that I said Mahler and not Wagner. This is gonna haunt me now. This is gonna haunt me potentially for the rest of my life. And nobody tell my students. It'll be a secret between the 100 or so of us. I love Mahler. I actually love Mahler. Mahler 2 is one of my absolute favorite pieces of music. And if you are not familiar with the Mahler Second Symphony, it's also known as the Resurrection Symphony. It's an absolutely breathtaking piece of music. It's sometimes referred to as Beethoven's 10th Symphony because it's sort of the it feels like, in terms of how it's written and how it's put together, that the Mahler Second Symphony really owes itself to the Beethoven's Ninth Symphony, which is the Ode to Joy that I'm sure many of you know. Okay, sorry, expanding your horizons. I want to challenge you all to stop thinking in categories of sacred and secular. And there actually is research from the field of ethnomusicology that suggests that for a wide swath of the American population, that there really is not a difference between secular and sacred music. And we see this as the baby boomers are starting to age more, that, you know, the music, and you all have probably seen this too in research, that there's an uptick in the number of people who consider themselves spiritual but not religious, right? So there are a lot of people who find deep spiritual meaning from music that we might have previously considered to be secular. I think of the song Landslide, Stevie Nicks. I think Landslide is a deeply, deeply spiritual song. There's a lot to be learned. There are a lot of spiritual lessons in The Gambler by Kenny Rogers. There are all kinds of, honestly, there's a lot to learn from good old TLC. And not everybody is going to get the same amount of meaning out of traditionally religious music. And also, there are a lot of people who are going to get deep spiritual support from music that we might traditionally consider to be secular music. So try not to think so much about secular versus sacred. And just like how every experience in life can be a deeply sacred moment, depending on where we are and how we are experiencing life and where we are in our life processes, the same thing is true for music. Anything can become deeply, deeply spiritual, depending on how life is going, where we are, what we are experiencing, and the experiences that we are having in relationship to that music. So again, go beyond the hymnal, go beyond the service books. Those songs certainly serve a purpose, right? I happen to be an ELCA Lutheran, and Lutherans love music. We love singing in 4-part, maybe 8-part harmony. You know, it's not a Reformation Sunday without a mighty fortress is our God. So there are songs, you know, there are traditionally sacred songs that are very important to people. And there are rituals that are very important to people that are rooted in music. But I also want to make sure that you remember to look around and look beyond the hymnal and see what songs might be important to somebody spiritually that are not necessarily religious. And that goes along with meeting people where they are. You all are fantastic at meeting people where they are. But think about that musically too. And what I mean is that if somebody is having just a really, really bad day, maybe don't flip on Enya for them. And this is a good piece of advice for you as well. If you are having a really challenging day, a rough day, try turning on some angry sounding music. Meet yourself where you are. Mine happens to be death metal. My students know that if they can hear death metal coming out of my office door, that they probably should back away and come see me another time, because I'm probably not in the best mood. And then gradually I moved from death metal down to, you know, heavy metal, and then to classic rock. And eventually we get down to where I feel like, oh, you know, maybe Enya's a good idea. I keep picking on Enya. I use Enya a lot, and I actually really like Enya. I like to have it on in the background when I'm doing work. Use the elements of music to support your work. So remember, music is not a single solitary thing. Music is a complex acoustical signal. So we have rhythm, we have timbre, or the way the different instruments sound. That's related to the overtone series and the physics of sound. So we have rhythm, we have timbre, we have melody, we have harmony, we have lyrics, if there are lyrics. If there are multiple instruments, then that adds to the complexity of the musical signal. But remember, we can use the elements of music to support what it is that we're doing. So if you are trying to, you know, help somebody get from point A to point B, now this is no longer going to be generationally helpful for a particular group of people. But I used to have a patient who, whenever we needed to get from, say, her chair to her room, or from the day room to her room, she loved Patsy Cline. And so I would start singing, I go a walking after midnight, out in the moonlight, just a hoping you may be somewhere a walking after midnight, searching for me. And that, it's a musical cue, you know, to go, oh, we're walking. Or even just tapping somebody's hand to get them used to the beat. where you can, get them to where they are walking in a particular pattern. If you have a patient and you need them to get their arms to go up, we call this pattern sensory enhancement. We can make musical gestures that go up in pitch, or you could sing a song that goes up in pitch. If you want somebody's hands to come down, right, we can think about having the pitch come down. So you can use the elements of music. It doesn't have to be a song. It doesn't have to be a real song. You could just make up things to help people support whatever it is that they're doing. You could sing a prayer to somebody. It doesn't matter what the melody is. It doesn't matter if you make it up right there on the spot. Right? That's how new works of music are born. The last thing I want to ask you to do is to dig for details. Think about the details about artists and instrumentation and albums. And it's Christmas time for those of us that celebrate Christmas. And there are, 50,000 renditions of Jingle Bells. Everybody has recorded it, or Sleigh Ride. And then we have covers of songs. So when you are thinking about using music with a person, make sure that you're digging for details about, okay, who are the artists that maybe originally recorded this? What is the instrumentation that was used? What were the albums that there? And I have a story for this, but we're going to run out of time, so I can't tell you the story. I apologize. The only people I think who love to tell stories, maybe almost as much as chaplains, are music therapists. So this is a list. This is a link to a list of resources. It's a Google document, and you can use this Google document. You can add to it. There are some resources that are already there, and there are some more resources that I have to add to it. But you can also add resources to this Google document. Anybody who has this link, and we can send out the PowerPoint. And Andy, I don't know if you can, whenever I try to copy the link, it gets angry and it forwards my slides. But it is bit.ly/music resources for chaplains. And if you type that in, it should take you to a Google document where you can find some hopefully very useful resources, websites, books, other things that might help you in your work with your residents. And then lastly, we are really going to come up on time. Lastly, this is a link to a Qualtrics survey. And this is where there are 3 questions that, I still can't make the link work. There are 3 questions for you to answer. And they are about what you learned, what you would have liked to have learned, and something practical that you can take with you to work with your residents today. That information is going to be incredibly helpful to me and the rest of the research team as we start creating more resources for chaplains, especially chaplains who want to use music with residents who have Alzheimer's disease and related dementias. I am out of time, and Andy, I think I'm going to give it back to you.
Thanks, Megan. Hold on a second. I just wanted to bring to folks' attention 2 upcoming webinars. One on Tuesday, prioritizing spiritual care and healthcare, a moderated conversation about the strategic priorities for professional chaplaincy. That's on Tuesday, 3 p.m. Eastern, 2 p.m. Central. And one that we just announced today, I sent out a promo this morning. Next Friday, December 16th, 12 p.m. Eastern, 11 a.m. Central, spiritual care HCPCS codes. That's brand new. Recently, the Center for Medicare and Medicaid Services has approved the first healthcare common coding system codes usable by all healthcare chaplains. So we're very excited about this. We apologize for the quick turnaround, but we're getting the word out among all our colleagues and networks. So please, either you can take a photo of that QR code, type in the bit.ly in your browser and register. And we look forward to being with you hopefully next Tuesday and definitely next Friday. Thanks so much. Thanks, Megan.